Okay, so today I'm gonna talk about what is a chest X-ray. So it means the definition of a chest X-ray. Indications are why are we doing the chest X-ray? When should it be requested? Why does the clinician ask for a chest X-ray? What does he want to see? What does he want to know? Third is how is a chest X-ray acquired? It's actually the technical methods and how does the technologist acquire the X-ray. We have technical considerations are exposure factors, patient position. Then we have the evaluation criteria. This is how to indicate or tell that this is an adequate chest X-ray. This is a proper chest X-ray and that I can diagnose it and make use of it. And then we have pathology. So first of all, what is a chest X-ray? So this is a chest X-ray. The chest, or let's say the thorax, is the region between the neck and head and the upper abdomen. This is the chest, and when you acquire a chest X-ray, you actually X-ray this region. Alright, so what does this region include? It includes the lungs full of air. We have the left lung, we have the right lung, and it includes the mediastinal area. The mediastinal area is right here. It's the area between both lungs. It has both costophrenic angles. Costophrenic angles. Costophrenic means phrenic is pertaining to the diaphragm. So here we have the dome of the diaphragm. This is the left dome of the diaphragm. This is the right dome of the diaphragm. And cost is pertaining to the rib. So this is the costophrenic angle. This is inferiorly, and then laterally you have to include the wall, like the chest wall. This is a chest X-ray, so indications. When we speak about indications, it means why is the chest X-ray being done. So first of all, and what's really amazing to know is that a simple chest X-ray can give you a huge understanding of the patient well-being. So that's why the first indication when you have a medical checkup or you have a new staff coming to work in a hospital, or you have the medical commission tests when you have expats coming to the country, they usually have a chest X-ray because it gives you an understanding of the overall health of the individual. Now that's the first indication I can recall. We have a couple or a group of conditions that are pneumonia, lobar collapse, we have pulmonary edema, symptomatic pneumothorax. Now this is a very crucial point since pneumothorax is an emergency pathology and we have to deal with it within a time frame. So acquiring a chest X-ray is really critical in this phase. You have tension pneumothorax, and that's the advanced form of pneumothorax. You have pleural effusion, and that's the deposition of fluid within the pleural cavity, and it has a very special appearance on a chest X-ray. You have COPD, chronic obstructive pulmonary disease. You have asthma. There's pleural disease that includes the pleural effusion. You have tuberculosis and asbestosis that goes under the family of occupational exposures. So this is a group of pathologies that we can see on a chest X-ray. One additional thing that is very interesting also, in the acute abdominal series, or acute abdomen, when patients come to the emergency are suspected to have a bowel obstruction, which is a severe urgent case also, emergency case also, we do a chest X-ray. And why is that? Because if you have free air in the diaphragm, since the density of the air is low, it tends to rise against gravity because it's low in density, and it situates right underneath the diaphragm. And just like in this area down here, you will see fine black lines. This indicates free air, and that's an emergency case that requires fast intervention. Okay, so we talked about how the technical considerations and the indications. Now, how is a chest X-ray acquired? So this is the position. This is the basic position actually of a patient that is gonna have a chest X-ray in the erect position or the standing position in the PA view. PA view indicates the posterior anterior view, and that means the ray entered the posterior aspect of the body, that's the back, and has exited the anterior of the body, and that's the front. The X-ray tube is here, it's just not visible to us right now, and the rays come from the back and exit the front. This is the PA view. This is actually the universal view, or let's say the basic view for a chest X-ray, because it has many advantages to it. Now, first of all, is the heart. In a PA chest X-ray, the heart comes within the normal size usually. It is not distorted. It's normal size. It shows what the heart size it actually is. Unlike the AP, when you have the AP view or the anterior aspect of the body receiving the X-rays and then they come out from the posterior aspect of the body, you will have distortion in the size of the heart. The heart will be enlarged, and when reporting such case, you can report that the patient has a cardiomegaly when it's not true. So this is something to take care of. Another thing in the evaluation criteria is the marker. Here, this says the left side. So normally we have the left side of the chest includes the heart. This is in the normal case, but then we have special cases like dextrocardia or situs inversus. This is when the heart is situated in the right thoracic region, and this is when the marking becomes very crucial, because if you have marked the left side when the heart is on the right side, then if the patient is to undergo treatment or to undergo a biopsy, then the side can be mistaken, and it's a very crucial thing to consider. Another thing in the evaluation criteria is actually the patient position. So when do you know when your patient is positioned properly? Is looking at a group of aspects within the chest. So number one, we have rotation and tilt. Tilt is when the body moves from side to side or from left to right. When the chest radiograph is tilted, you will realize that the spine has gone towards the left or towards the right. This is how you indicate tilt. And the second is rotation, and that's the crucial aspect, because rotation in the chest can change its appearance. Rotation is indicated by the rotation of the thorax or the chest around its axis within a certain degree, and that's seen in the distance between the clavicle and the sternum, in the sternoclavicular joint right here. The left sternoclavicular joint space should be equivalent to the right sternoclavicular joint space. The space has to be equal to each other. If one is bigger than the other, then there is rotation towards either side. Another part of evaluation criteria is density. Now, normally we know that the lungs are full of air, so they should appear black. And the bone, since it contains minerals and it's higher in density, it shall appear white. Now, it should not be black to the extent that it's burnt out, because we have to see the lung markings right here. You see the vascularity coming out from the heart. These are actually the heart vascularity, and these small white areas, or it's like a spider web appearance, these are the lung markings. We call them lung markings. So lung markings have to be visible. This indicates that the radiograph has been exposed adequately and the correct radiation dose and the exposure factors have been used. So that's quite it about the evaluation criteria. Now let's come and talk about the anatomy in specific.